Dr. Swati. Our next speaker is Dr. Leon Au, who comes to us from Manchester Eye Hospital in England. He did a cornea, refractive, and glaucoma surgery fellowship. He was the first to bring MIGS to England, and he'll be talking about stenting versus cutting and new technologies on the horizon.
Thanks, Steve. Thank you, Tanush, and thank you for the Society for the invitation. And thank you for having 15 minutes to talk about devices that's been around for 15 years, and all the new devices, all in 15 minutes. So apologies, of course I'm going to bloody overrun this one. This slide is for the community, all my disclosure. But the most important disclosure for you is the fact that I am a stenter and I'm not a ripper. And I thank everybody else who has shown the slides and the talk before of all the ripping procedures and all the blood that you've seen. I don't like to see any bloods, and I'm a stenter. And I've got a good reason for it, and hopefully at the end you're going to be convinced. This is Tanush slides. Tanush thinks that these are all rubbish, and hopefully he'll be convinced it's not 100% true. I'm a stenter, and all we here is to restore physiology, as you know. And we all started with the Glaukos istent, which seems so long ago now. And at least 15 years ago, the first device that the G1, I gather, is still here. In India, they've stopped it, and I love the G1, which bypasses the meshwork, as you know. And then this is what we're trying to do. Look at the vessels inferiorly. This is the single G1 that I put in some years back, around about 2009. And all we're trying to do is to bypass the meshwork. So once you've got a G1 in, you put some vision blue in, and you can see it flow out to the vessels. You can see that we're establishing anatomical connection with collectors here. So even back then, you argue about 1 stent versus 2 stents versus 3 stents. If you're going to win the lottery, you buy more than 1 ticket. You're more likely to hit the collector channels. Then, of course, multiple stents does appear to work a bit better. So then Glaukos very quickly came out with the G2, which is the inject, which is a bit smaller, and then you get 2 goals. You get 2 opening, and you double your chances of hitting the collector channels. I love the fact that they've made it slightly bigger, which is the W, which I do like. It stops you from over-implanting a little bit. And I'm excited the fact that now we can put 3 in. You can laugh about the cost. Everything costs in life, okay? But you get 3 chances of hitting collector channels, and I'll show you a little bit about the infinite. But this is what 3 stents looks like. This is me, 3 eye stents W, 1 in the middle, and the other 2 as wide as possible. So we are going as 6 clock hours as you can, and no device that will allow you 6 clock hours of entry without ripping anything and bleeding everywhere. And then the idea is that within these 6 clock hours, you are likely to hit some collector channels. And I think we're increasing our chances of hitting the channels versus the hydrus, which is about size. And size versus access is a battle I'm still having in my head. Watch the vessels superiorly as we irrigate. Look at that vessels gradually blanching away. We've hit collector channels up there 6 clock hours. You see the vessels just blanched away as we irrigate and remove the viscoelastic. So of course, I'm the biggest user of vision blue in the world, and I'm flushing the vision blue, and you can see how the collector channels light up 6 clock hours up there. And that's what multiple access points going to give us, multiple access to collector's channels. I don't believe you need to rip all the meshwork to hit where you need to hit. And then, of course, if you believe in size, then we have the hydrus you hear about, that it is a bigger device. And if you think bigger is better, and not everybody can take a big device, not every vein can take a brown venflon. But if you hit the right vein with a big device, you probably get more flow. So this is a hydrus going in, admittedly using the Glaukos gonio. It's ironic, I know. And this is the hydrus crawling in. It takes a little bit more skill to get it in. I do not believe it's a difficult procedure. Let's not get you carried away. It's difficult to put in. But once you get it in, make sure that it's kind of inserted correctly. And then you can see the hydrus sits in circumferentially with not a lot of it sticking out. And then you span about 2.5 clock. Watch the vessel superiorly as I pressurize the eye. Watch it, boom. You see that wave of blanching just with purely pressurizing the eye. And that's 2.5 clock hours of a hydrus at the top. So when you hit the right canal with a big device, That's the sort of blanching you're going to get. And when you put some blue in, then you're going to see the diffuse outflow that we managed to tap into as you put the blue in. And it's quite phenomenal when you get that. I mean, this literally lights up blue everywhere. And that's quite amazing. And that's why we stent, because I still believe it's the best procedure to combine with phaco. If you come in here for a phaco, you want to see 6/6 the next day, unaided, with a toric lens implant, possibly a premium IOL, you don't really want an eye full of blood. And when you're going to cost your study, you better cost your complication too. So I still think it's the best, and we have the best data. We have the FDA trial, all of them, phaco versus phaco stent. And nothing else, no other ripping procedure has this randomized prospective trial. So you can't argue with the data that adding a device gives you extra pressure lowering. Everybody's seen the data. Istent, hydrus give you almost up to 2 millimeters of mercury more than phaco alone. When you wash them out, you're about 20% chance more likely to get success when you put a device in. This is the official istent inject slide, the pivotal trial, not the that's the W. So then it shows you that, again, you get a better medication reduction and you get more pressure lowering. We had it with the hydrus, which I was part of the investigator. We ran the study for 5 years. This is the 2-year result. So you get an extra 2.3 millimeters mercury drop, and then you're about 30% more likely to be medication-free. When we ran the trial for 5 years, it is still the only mixed procedure that was powered to run for 5 years prospectively. The medication, the IOP reduction remained constant for the 5-year period. Medication-free rate was 20% more likely solidly throughout the 5 years. And this is prospective good retainment for 5 years. MIGS have no long-term data. Well, I don't think you've looked very hard. So this is from Glaukos iStents. The group of iStents that we've had, admittedly they have changed device, have had some long-term data. Previous speakers already shown. The one with the heart is mine, will sadly be beaten by Paul with his 8-year data, beat me by a year. But nonetheless, we have long-term results. The numbers of patients are small, but what you're looking at, a pressure around about 16, 17, but more importantly, once you got a device in, we see them less often than we need to see them before the surgery. So we're now reducing post-op follow-up visit. And ultimately, MIGS has always been reducing medication count. And of course, it's important to get granny off drops. This is the sort of granny with terrible red eyes that you all have in your clinic that really you don't want. Reducing medication is important. We ran the hydrus for 5 years. We have now evidence to show you we are 3 times less likely to need subsequent glaucoma surgery when you put a device in. There's no argument about that. No one else has shown that. So you're less likely to need a trap or a tube or a diode. We have shown visual field stability. You are less likely to get worse on your visual fields if you have a device in like the hydrus. So again, first time we've shown that rather than reducing medication, we are now affecting glaucoma outcome. iStent, this is the latest paper. They have shown the same. You look at all the phaco iStents been done, visual field has been pretty stable throughout the follow-up period compared to a normal glaucoma patient where the natural history is to get worse. New devices that may be coming through to India and other parts of the world. The Omni has been around for a little bit, certainly in the States and in Europe. So this is when you dilate the canal. We've not talked about dilation, and if you're a believer in dilation, Omni is one of the devices that you can ab-internally cannulate the canal, and you inject viscoelastic to dilate. And you can rip as well if you want to rip and see some blood. And some people just don't feel like they're finished until they have destroyed the meshwork. But this is Omni, which is an ab-internal dilation. This is the one that I prefer, which is the iTrack, because we can ab-internally shoot a fiber optic with a flashing light. If you haven't seen it, it is amazing to cannulate the canal 360 degrees, that you realize this thing actually exists. It's not mythical. It does go all the way around. And the flashing light gives you confirmation you are going around, and you'll come back to see you in a minute. And then we inject viscoelastic to any degree that we like. We can inject whatever volume we like with the iTrack to give you the dilation that you need. And I like the iTrack because of that. Of course, now we can also make holes in the meshwork without ripping anything. So we can use an excimer laser. This is AIOC, which we have now. Excimer laser trabeculotomy, we create 10 openings in the meshwork. Each one, admittedly, is bigger than the istent if they stay open. And that is a big if, that each hole actually stay open. But this is ab internally. You can see that we fire it at the meshwork. We make 10 openings. It's early stage. We need a lot of work to validate the opening and validate the stability and validate the results. This is the coolest thing it's going to hit. Forget cost, people. This is a 250,000 pound laser. Okay, this is the first femtosecond laser that we're going to open up your meshwork using a femtosecond without opening the eye. You come here, you lay down, I dock you, I open your meshwork, and you walk out with no steroid and no antibiotics, and you go and play golf afterwards. So this is how it's done. This is the first image-guided, OCT-guided trabeculotomy. So you lay down, you can see an intraoperative gonial. Amazing view, really. Amazing view. We have a great talk about how to put a gonial intraoperatively. You can forget about it. And then you can place your sclerotomy window anywhere you like. So we place it temporally here. You can put it anywhere you want. Any part of the angle that looks good. And then press the pedal, femtosecond do the rest. It will give you a 500 micron opening. And then you just walk out without the eye being open. So this is not surgery. This is an office-based treatment, essentially. So that's a long way to go. We're going to have to see the results. Of course, we can stick things in suprachoroidal space too. We've been there before with the SiPass. We're going there again with the MiniJet iStar. Totally different game, totally different profile. We're going into suprachoroidal space by inserting what we essentially a silicone sponge. Looks a little bit gruesome, a little bit higher potential risk profile. I've been surprised so far by how safe it actually is. It does take a bit of getting used to, and you can easily cause a big cleft or ruin the iris if you're not careful. So it demands a lot more to the surgeon. But post-op complication in terms of hyphema, pressure spike, and so forth, I'm surprised how little it has been. And in terms of the visual outcome, it has been quite good. And so I'm a little bit amazed, and I've been a little bit cautious with suprachoroidal space because of the SiPass before. But endothelial cell count seems to be okay at the moment. So we're inserting a sponge that basically with multiple holes to allow the fluid to escape. Why am I excited about the MiniJet is the fact that we're now moving into standalone procedures. We're not leaning on that phaco that Steve has mentioned that drops your pressure. We're looking at standalone. This is 3-year global MiniJet data standalone. We're dropping the IOP now by a substantial amount to around about 15 as a standalone procedure. And I think that's the big key where we're going with mix is the fact that we're not leaning on the phaco anymore. So, and I want to show you, come back to the infinite that I told you about. We're talking standalone. This is FDA approved. Standalone study. The FDA study was in patients who's either had previous failed trap or maximum tolerable therapy. Okay, so this is what we define as refractory glaucoma. We have standalone iStent inject infinite, 3 iStent inject standalone. And that is the study that got FDA approval. We are having, again, substantial IOP lowering, but especially in the MTMT group, 8 millimeters of mercury drop as a standalone procedure. And that's quite impressive, with either the same medication or less medication than before. So we're demonstrating now substantial pressure lowering as standalone. I've got 1 minute left, and I'm going to end you with this particular one. This is what we've all been after. You get your IOP lowering, you get your medication lowering, you get your reduction in visual fields, you get your reduction in the need for glaucoma surgery. What's in it for the patient? We have the very first quality of life outcome from one of these FDA pivotal trial. And with the hydrus as well, we did this, quality of life assessment. For some reason, that never got published, so it kind of tells you something maybe. But this is one from Glaukos. Give it credit. When you look at the quality of life outcome of the pivotal trial, people who's had an iStent with the phaco has overall a better scoring of quality of life, better scoring for the ocular surface indices. And more importantly, many aspects of the daily activity appears to be improved, but particularly interesting was the driving. They feel that they drive better. Equal amount of vision, but yet by having a mixed device, they feel that the driving ability improved, possibly because of ocular surface and less medication cap. So there you have it. Hopefully you are convinced that stenting is the way to go. And if you're not, you can email me and we can chat a little bit more. Thanks very much.
You make a great case for stenting versus removal of the